evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Mission Knee webinar. And the topic is New PPH Guideline Changing the Way the World Saves Mothers. It's my privilege to introduce the expert and program director of this webinar, Dr. Sharda Jain ma'am. Ma'am is the founder and secretary general of DGF and the founder and chairperson of North India Gynecologist Forum. I welcome you, ma'am. And it's my honor to introduce the moderator of this webinar, Dr. Archana Verma, ma'am. Ma'am is the Vice President of Foxy in 2021 and advisor of UPCOG. I welcome you, ma'am, and I hand the session to you.
Thank you. Thank you, Sahiti. So I welcome all and the greetings from Ghaziabad. With the blessings of our patron, we proudly commence the academic session initiatives. And today's Mission Knee webinar, I think almost 95th webinar going on. And today our star speaker is none other than Dr. Shashi Kabra. And I want to say just about our patron, Dr. Sharda Jain Vision, is to share these guidelines and PPT to each and every gynecologist across India so that many people can read it and they get versed with it. And so there's a lot of clarity and a lot of uniformity. So whenever one is working, they also talk on the same tone. And this is definitely an academic gift from respected Dr. Sharda Jain. And it is a tool to ignite awareness and to strengthen alertness and to work more unitedly and inspire proactive care for the patient through the birth preparedness and knowing all about the strategic points and way of working, so that when patient is not you are not able to even handle or give the proper care, you can refer to higher center or tertiary center in a vertical way so that the patient gets the bestest of care and you take care of the time bound things and those schedules also. Everybody should be knowing what are the preventive steps and what are the diagnostic step and what are the treatment steps. So we aim to transform this vision of reducing maternal mortality by doing this. And I'm 100% sure that soon we will be reaching the SDG goals and India will be the champion in the at the global level also, with all the dedicated people like Dr. Archana Sharma. She is here as an expert, and Dr. Shashi Kabra as a speaker. And when we have a good speaker and good motivator, we can achieve a lot. So welcome Dr. Shashi Kabra. She is a big name. Everybody knows her, and she is a consultant and super time administrative grade department of OBGY DDU hospital, which is a big hospital of Delhi Health Services, and she is at present governing council member in ICOG and chairperson Safe Motherhood Committee of AOGD, which is a big society. And she is actually chairperson of committee for preventable maternal mortality, again in the NIGF, which is a big forum of North India, and associate member of prestigious RCOG. She has been decorated with many awards, including, you can see the list of awards, and not to say I'm so proud of her as a friend. So welcome Dr. Shashi Kabra to give your speech and oration, and I welcome Dr. Archana Sharma as expert.
Yeah, thank you so much, ma'am, for such a kind introduction. आपके इतने बढ़िया शब्द मैडम ये हमेशा एनकरेज करते हैं कुछ और अच्छा करने के लिए. So is my slide visible?
Yes.
Yeah. So when we talk about PPH, ये शारदा जैन मैम का बहुत बड़ा मिशन है, विजन है, और जो उन्होंने सोचा है, डिफिकल्ट थिंग मैडम सोचती हैं, पर ये सब इजी हो जाते हैं बिकॉज ऑफ द डिसमिनेशन ऑफ नॉलेज. एंड जब व्हेन वी टॉक अबाउट पोस्टपार्टम हेमरेज, इट इज स्टिल द कॉमनेस्ट कॉज ऑफ मैटरनल मोर्टेलिटी इन इंडिया. तो यदि हमको मैटरनल मोर्टेलिटी कम करनी है तो वी हैव टू फोकस ऑन दिस. And I really appreciate ma'am's vision of sharing the same PPT everywhere, all over India, so that some uniform actions can be taken. So everybody knows about the definition of PPH. The incidence is 2 to 4% after vaginal delivery and 6% after cesarean. So I would like to say that today, when I joined DD Hospital about 25 years back, I used to make statistics of different type of deliveries in my hospital. So the incidence of cesarean section was 21 to 25%. And now it has increased to 35% in government hospitals. And when I go for NB accreditation at different places, I see at many places it is around 60 to 70% and even reaching 80%. So we have to take care that unnecessary cesarean section should not be offered to a woman. And here I would also like to add one important thing. If a woman wants a cesarean on her own request, or whatever reason which is not justifiable, it is my duty as an obstetrician to tell her, see, with one cesarean, you have 10% incidence of placenta accreta spectrum, with two cesarean, 20%, with three cesarean, 30%, with four cesarean, 40%, and so on. So we have to focus on prevention of primary cesarean. Then in rural areas, the incidence of postpartum hemorrhage is 12%, and the maternal mortality on average is 27%. But if we consider different parts of India, then it varies from 27 to 58%. In many remote areas of Rajasthan, Odisha, UP, MP, the Assam, the incidence may increase up to 50 to 58%. So FIGO and WHO, they have made a new guideline and made some changes in the old guidelines in 2025. And the guideline was published in October 2025 in the um, FIGO conference. So every facility should be ready and equipped and trained for managing PPH. And in single word, every woman should be delivered in a facility, not at home. Delhi is doing a good work in preventing home delivery. And every birth should receive active management of third stage of labor. Active management of third stage of labor prevents postpartum hemorrhage by 50%. Here we give injection oxytocin within 1 minute. So there are two important points. One is injection oxytocin, and second thing is within 1 minute. That should not become 1 minute and 1 second. So by doing that, we already decrease the incidence of postpartum hemorrhage by 50%. Every woman survived without preventable morbidity. PPH is preventable, and if at all it occurs, then it is treatable if we take actions in time. So our goal should be end death due to PPH by 2030. सोचने पर एक बार लगता है कि शायद ये difficult है, but you believe me that it is possible. And I feel myself very fortunate enough to share this of my thought with everyone all over India. और मुझे हमेशा लगता है ये कि मैं लोगों को ये बताने में सफल हुई हूँ कि पीपीएच की डेथ जीरो हो सकती है. So here in postpartum hemorrhage, we have to recognize, we have to act fast, and we have to escalate our treatment. We have to be vigilant for early warning signs, early diagnosis, quick response, and prompt treatment. All these will prevent postpartum hemorrhage deaths. So when blood loss is, in earlier definition, it used to be said that blood loss more than 500 ml after vaginal delivery, more than 1000 ml after cesarean, and any type of blood loss which causes hemodynamic instability in a woman is defined as PPH. But this guideline has added one more clause to this, and that is if there is equal to or more than 300 ml of blood loss, but some warning signs are present, then this too will be called a postpartum hemorrhage, and we have to act immediately. Like these are atonic uterus, heavy blood loss, large clots or constant trickle of blood, or there is a change in vital signs like pulse more than 100 per minute, systolic BP less than 100, diastolic BP less than 60, and shock index more than 1. And when the blood loss is more than 500 ml with no other sign, also it is a PPH. Now let me focus on these pulse and systolic blood pressure. Let's first come to shock index. Shock index means fetal heart rate divided by systolic blood pressure. In normal non-pregnant women, it is 0.5 to 0.7. And in a pregnant woman, there is a hypervolemia. So the normal value is 0.7 to 0.9. If the shock index becomes more than 0.9, then the patient is hemodynamically unstable, and we have to treat her PPH aggressively. Now, suppose there is a patient, I had a patient whose pulse was 104 and her BP was still 1 by 80, but her pulse was more than 0.9. So You feel that her systolic and diastolic BP are normal, but she is still shock index is less than more than zero point 0.9, so she is unstable. Second thing, sometimes in an emergency, we do not remember so many things. So I used to call it rule of 100 for my own PG students. Rule of 100 means if pulse is more than 100 and systolic blood pressure is less than 100, become alert. There is wrong something. Look for PPH. Treat it aggressively. So identify the high risk factors for PPH in every case. There are few conditions like previous postpartum hemorrhage, twin pregnancy, then many women who has anemia, preeclampsia, prolonged labor, maternal infection, augmented labor, induced labor, the chances of postpartum hemorrhage is increased. But remember one thing, in spite of not having any high risk factor, a patient can have PPH. PPH is so unpredictable. So you have to always become PPH conscious. Now you give a uterotonic, place the blood measurement tool, deliver placenta with controlled contraction, check uterine tone and massage if soft, check bleeding and monitor every 15 minutes. Uterotonic of choice is oxytocin, 10 units intramuscular. One can give carbetocin also as a prophylaxis, and those places where somehow the oxytocin temperature cannot be maintained, one can use misoprostol as a prophylaxis, 600 microgram. Then there should not be any hurry in removal of the placenta. Beautifully by controlled contraction, it should be done, and we should avoid uterine inversion in any circumstance. Uterine tone is to be checked. Now it is said that since we give after the patient has delivered, since we have already given oxytocin, so the uterine tone is only to check. Routine massage is not indicated, but massage is done if there is PPH. So the oxytocin is maintained at 2 to 8 degrees centigrade temperature, and it can be given intramuscular or intravenous, and the time should be 1 minute. Then come to carbetocin. Oxytocin by and far the commonest drug of choice. If carbetocin is available, we can give carbetocin also. The only advantage of carbetocin over oxytocin, which is well established, is that carbetocin is heat stable. Uh, a few literature and few small level trials have also said that carbetocin better prevents postpartum hemorrhage compared to oxytocin. But still, the drug of choice is oxytocin. Both the preparations of carbetocin are available, heat stable and non-stable. And misoprostol, I've already told you, it can be used sublingually or per rectal. So remember that for prevention, we have three medicines. One is oxytocin, second is carbetocin, and third is misoprostol. Now, place the tool for measuring blood loss accurately. It is mandatory. There used to be a quantitative and qualitative estimation from the main sheet. So what we do, we push it below the patient's buttocks first. When the patient delivers, it does not expose. When patient delivers, the liquor flows down. And after that, we just pull it out and hang. So the blood loss is now correctly measured, exclusive of amniotic fluid. So this precaution can be taken. And other innovations, like if we are using mops or gauzes, then 1 gram gauze is equal to 1 ml blood loss. Mops, there are different categories, 25%, 50%, 100%. That way we can estimate blood loss. One full feast of blood clots means 500 ml blood loss. So these are the other quantitative methods. And if we are doing cesarean, then we can measure the blood loss in suction machine also, excluding the Leica amount. Sometimes a patient continuously leaks slowly, continuous trickle. That should not be underestimated. So the message is that you should objectively measure blood loss and quantitatively. For the cord, you wait for 1 to 3 minutes. This transfers about 60 to 80 ml more blood to the baby. But if the woman is bleeding heavily, you cut the cord immediately because you have to resuscitate the women. And controlled cord traction. It is very dangerous in unsafe hands. We have seen patients in our hospital have come with uterine inversion because the cord traction was not done by a skilled person. Never pull hard on the cord and stop if resistance is failed to avoid tearing of the cord and uterine inversion. So uterine inversion is a dangerous complication of improper cord traction. Rather, I would like to say the cause for uterine inversion is most of the time iatrogenic. Then check the tone. Massage only when soft. I have already told that when the uterus feels atonic, only then we give massage. Uterus should be firm at midline and at the level or below the umbilicus. If the fundus rises or is off to the side or becomes soft again, it may be full of clots or bladder may be full. So one important management is catheterization. By catheterization, there are two advantages. Because of full bladder, it also interferes with proper uterine contraction. So it will initiate good uterine contraction. And by noting the amount of urine, we can know about the hemodynamic condition of the patient also. And check the uterus at least every 15 minutes for the first hour. Remember, always you should have an IV line for the patient who is delivering. And I visited many labor rooms in Delhi, either as a lecture mentor or for PPH and other maternal family health program. And in many labor rooms, I used to see that there is no gray cannula. So I request that every labor room, every maternity OT should have a gray cannula because the green cannula transfers only approximately 90 ml of IV fluid per minute, and the gray cannula about 180 to 200 ml. So in PPH, we have to rush intravenous fluid, and that is life saving. So everyone is requested to keep gray cannula set in their maternity OT and labor. Now, I've already told you that oxytocin and misoprostol can be used for the prevention and also carbetocin. But oxytocin and misoprostol can also be used for treatment, but we cannot use carbetocin for treatment. It is only for prevention. There are two C's in the management of postpartum hemorrhage. One C means carbetocin and another C means carboprost. Just giving you a simple tip. The first C, carbetocin, is only for prevention, not for treatment. And the second C, carboprost, only for treatment, not for prophylaxis. So you can remember it that way. In every case of PPH, the moment you have made a diagnosis of postpartum hemorrhage, you are supposed to give, that is recommended, injection tranexamic acid 10 ml IV over 10 minutes. Irrespective of the type of PPH, whether it is traumatic or atonic or coagulopathy, and irrespective of the type of delivery, whether vaginal or abdominal. And it is given only after you suspect PPH. It is not used as a preventary method. Now, how to feel whether the uterus is hard or contracted or it is soft. So hard uterus feels like forehead, soft uterus feels like the tip of nose. Uterine tone can change quickly. Uh, Full bladder may slow uterine contraction. And if the placenta is not out, there is heavy bleeding. And you start PPH treatment bundle immediately. And if the placenta is not removed, then we have to do manual removal of placenta under anesthesia. Check for bleeding if more than 300 ml blood loss with warning signs, or more than 500 ml blood loss as such, or if the patient is hemodynamically unstable, then you start PPS bundle. So what is PPS bundle? PPS bundle has got many components, starting from the IV fluid to uterine, use of uterotonic, to the surgery and hysterectomy is the last resort, and blood transfusion. So the guidelines say that you use every modality of the part of the management of PPS bundle in 2 hours, preferably in 1.5 hours. And you must settle a case of postpartum hemorrhage in 1 to 1.5 hours. यदि आपको, if you want to do a hysterectomy, then you do hysterectomy timely, sooner rather than later. Now for monitoring, we need to monitor pulse, blood pressure, shock index, and it should be done very frequently, 15 minutes. And our first assessment will be of the tone, volume of blood loss, blood pressure, and shock index more than 1 is dangerous. It should be below 0.9. If placenta is not out after 15 minutes, empty bladder and repeat control contraction. And placenta not out after 30 minutes or retained fragments, remove manually. If part of the fragments are left, then under anesthesia, we have to remove those small parts by a ovum forceps or a sponge holding forceps or with a anterior vaginal wall retractor. We do not use a sharp curettes in a postpartum case. We preferably use anterior vaginal wall retractor. Now, our next job is to check placenta for completeness. We have to identify the missing lobes. And if any lobe is left inside, then we have to take it out with the help of the instrument. If the uterus is firm and placenta is complete, but bleeding is there, then it can be a traumatic PPH. And if the uterus is contracted, then it can be traumatic PPH. And if the uterus is soft, then atonic PPH is the commonest cause, around 70%. For traumatic, the incidence of atonic PPH is 70%. For traumatic PPH, it is 20%. And in my experience of last 25 years in DDU hospital, I have seen that we are the cause, doctors and nurses are the cause for causing this traumatic PPH. Dr. Rachana, do you believe this? Hello? Dr. Archana? Either we use, either we apply fungal pressure or we use an instrument in a wrong way, like forceps or ventouse, and that leads to traumatic PPH. Dr. Archana, am I audible?
Yes, 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 yes.
Ah.
बिल्कुल
So
audible है मैं
I was just asking you that the cause for traumatic PPH, it is most of the time iatrogenic.
yes, yes, I listened. तभी
Yes, okay.
okay, but I don't want to say that कि मतलब just beware of that
Yeah,
traumatic also because
yeah.
in the so many times we just keep on thinking कि अगर हमने
Mhm.
just लगा दिया यूट्रोटॉनिक्स दे दिया तो हमारा
Yeah.
सारा काम बन गया और we don't even
Mhm.
think कि वो जो
Mhm.
हायर वो हो सकते हैं ब्रॉड लिगामेंट हेमाटोमा तक जाया
Yes, yes.
गया होता है you
Uh,
are very right,
So,
very right.
yeah,
Go.
so broad ligament hematoma does not happen as such. We apply a fungal pressure or we use an instrument in a faulty method, so that's why it happens. Anyway, so assess the baby, check her color, temperature, breathing, and cord. Record on newborn chart, start skin to skin, and encourage breastfeeding and assess the women. Check uterine
Actually,
tone, blood loss.
डॉक्टर शशि वो मैं हमेशा ये कहती हूँ सावधानी हटी और दुर्घटना घटी वो वाला बहुत सिंपल सा फॉर्मूला है मतलब
Yes.
कोई भी चीज आप इंस्ट्रूमेंट भी लगा रहे हो तो मतलब बहुत उसको उसके इंडिकेशंस होने चाहिए उसका प्रॉपर वे होना चाहिए और उसके साथ आपको ना उसमें बहुत किसी सीनियर के साथ बहुत अच्छे से सीखा हुआ होना चाहिए और कॉम्प्लिकेशन पहले पता होना चाहिए करने से पहले व्हाट
Yes,
नॉट
ma'am.
टू डू
Yes, ma'am. I have seen many cases where forceps application was done in a wrong way, and that had led to broad ligament hematoma and death of the woman. So ये बहुत
यू आर
जरूरी है
वेरी राइट जब वो जो ये जो ब्रॉड लिगामेंट हेमेटोमा होता है कोई कितना ही झूठ बोले मतलब इट इज ऑलवेज द फॉरसेप्स
yeah, it is always a forceps of fungal pressure.
हाँ
That's what we are.
ओके
Yeah. So teach the women how to check and massage her uterus, encourage frequent urination, ask her to speak up if she notices bleeding. After 1 hour, if stable, no bleeding, remove the blood loss measurement tool and move her to the postpartum ward. Women and babies should stay together in the facility for 24 hours after a normal birth. And if PPH, then start treatment bundle, PPH bundle immediately. So be alert, identify the high risk factors I've already told you. And even if the patient is not having a high risk factor, you should always remain vigilant for PPH. Measure vitals, feel the tone of the uterus, look for heavy blood loss, remove large clots, and also watch on the constant trickle of the blood loss. And always follow the rule of 100. If pulse more than 100 and systolic blood pressure less than 100, or shock index more than 0.9, rather, I should say, you become alert. So this is a summary of the whole thing. We are giving within 1 minute, you can give injection oxytocin, which is the drug of choice, or carbetocin or misoprostol, 400 to 600 microgram per orum. What you are assessing and recording, uterine tone, blood loss and flow, BP and pulse every 15 minutes. You are becoming alert if there is more than 300 ml loss with warning sign or more than 500 ml without any further sign, and by clinical judgment if her pulse and BP are deteriorating. So the early diagnosis is the first step for the treatment. Once PPS is diagnosed, call for help and start PPS bundle. हेल्प लेने में हमें घबराना नहीं है. मेरे लिए ये ज्यादा इंपॉर्टेंट है कि मुझे अपना पेशेंट बचाना है. In the management of postpartum hemorrhage, there should not be any ego problem. So call for help, emergency equipment and medication. I've given it a name as per lecture guideline. It is PPS toolkit. You make a box, keep everything necessary which are required for the management of PPH, and that should always be ready when we make a diagnosis of postpartum hemorrhage. And once anything of that box is used, you immediately replace it because we never know when the second postpartum hemorrhage occurs. In the management of PPH, resuscitation, treatment, management, everything goes simultaneously. So why do we call for help? We require 2, 3 people. Somebody is monitoring pulse, BP and keeping chart. Somebody is on hand side taking samples and starting IV fluid and blood. Somebody at the vaginal side for local examination. And one coordinator and leader who directs everyone to do what is to be done and what not. So remember the mnemonic motif. M for massage, O for oxytocin, T for tranexamic acid. Tranexamic acid is a wonder drug in the management of postpartum hemorrhage. IV means IV and E means examine. तो जब आपने पीपीएच डायग्नोज करा, आप फटाफट आईवी फ्लूइड लगाइए, ग्रे कैनुला के साथ लगाएंगे. The maximum crystallers you can give is 1.5 to 2 liters. इसका मतलब ये हुआ that you are giving 3 to 4 bottles of IV fluid crystallers. Um, and that has to be rushed because it is an acute hemorrhage, it is not a chronic hemorrhage. Avoid colloids, and if at all you need to give colloids, then don't give hexastarch, as it may lead to death of the women. You give succinylate gelatin choline, which is available as Hemexil. So you throw the hexastarch out of the labor room and maternity OT. Now coming to the massage part, everybody knows how to do the massage. That's an important component of management of postpartum hemorrhage. Now come to oxytocin. Now this oxytocin is not being used as a prophylaxis. It is for the treatment of postpartum hemorrhage. So you are mixing 40 units in 1000 ml and giving it at 40 to 60 drops. Then tranexamic acid, 1 gram 10 ml over 10 minutes. And it is mandatory to give in every type of PPH. And then you examine clinically and escalate your care. Locally examine whether it is a traumatic PPH or a tonic PPH, or there is written projects of conception or coagulopathy. I'm just sharing one of the experience for prophylaxis of oxytocin. Sometimes in my hospital, 4 or 5 women deliver simultaneously. So we have kept a ice box. Our nursing staff keeps pre-filled syringes of 10 units oxytocin in that ice box, and quickly they can give that injection within 1 minute, even if 5 deliveries happen at a time. So the message is that that 1 minute is very important. Tranexamic acid, you have to take one precaution that you have to give it over 10 minutes because faster administration can cause hypotension. And tranexamic acid and oxytocin can be given in the same line, but not in the same bag. Do not start tranexamic acid if 3 hours or more have passed since birth and you have not given it earlier. And also when there is a hypersensitivity reaction or non-thromboembolic event, renal failure, or history of convulsions. But usually very few, in practical life, very few contraindications are there for tranexamic acid. Here it is written as 18 gauge cannula, but I would advise 16 gauge cannula, which is a gray cannula, and it transfuses around approximately 200 ml blood per minute. So we can rush 1.5 to 2 liters of crystalloids in 15 minutes. We are putting cannula, you have to put the IV gray cannula in both the hands. So with one hand, we are rushing the crystalloids, and with another cannula in other hand or elbow, we have to draw samples for hemoglobin, CBC, blood for grouping and cross matching, LFT, KFT, and clotting studies. And remember, the fluid for choice is crystalloids, is ringer selected. Every labor room and maternity should have a lots of ringer selected. And if ringer selected is not available, then we can give normal saline, but it should always be made available. And if I'm giving oxytocin, then on one side, normal saline with oxytocin, and on another side, we should rush ringer selected. It is always preferable to make two IV lines. We should always make two IV lines for the management of postpartum hemorrhage. And regarding the causes, I've already told you. Just you can revise it. So atonic uterus is caused for the 70% cases, traumatic PPH for 20%, and tissues for 10%, and coagulopathy for 1%.
You can skip the if the repetition of the slides
Yeah.
is there, and then
Yeah.
you can skip those quickly.
So for traumatic PPH, you have to look for perineal, vaginal, and cervical tears. If inverted uterus, replace and follow local protocols. And this replacement, you should never do in an emergency. I've seen a woman whose uterus was tempted that uterine inversion was, she tried to correct the uterine inversion in emergency. She thought that she will be the first person to do it, and the patient died of neurogenic shock. Remember one thing, that uterine inversion should always be corrected in OT under anesthesia. And if you suspect uterine rupture, seek advanced care, take the patient to OT. So the last part, examination is done of motive and then escalate. If the woman is not responding to oxytocin, then you have to give methazine. You may have to give carboprost, and you may have to give misoprostol. Remember one thing, that when we have given misoprostol as a prophylaxis, then in that case, we do not give misoprostol for the treatment. We will choose other medicines like carboprost, oxytocin for treatment. And if the case has happened at a primary center and further management cannot be done, then we should arrange for the transfer of the patient. And if the patient is in shock, then we can use non-pneumatic anti-shock garment. It is a life-saving garment and can maintain the patient's BP for 2 hours. And you can do surgery even with this garment on, and give at least one shot of antibiotic to the patient and ask for blood transfusion. When you are using oxytocin, then please remember one thing, that you should not use more than 3 liters of normal saline mixed with oxytocin. It may cause water intoxication. And the maximum dose of oxytocin is 16 international units in 24 hours. Now, ergometrin, when we were doing our PG, we used to be taught that after the delivery of the anterior shoulder, you give ergometrin 0.2 milligram IV. But now this has been omitted. Now we are giving oxytocin. Oxytocin has replaced ergometrin. Then about a few years back, we used to be taught that methadone can be given as a prophylaxis. But now the methods in this guideline, latest guideline, methadone has been omitted from the list of prophylaxis for PPH. We are using it only for treatment. The maximum dose allowed is 1 milligram, 200 microgram, 5 doses in 24 hours. But remember one thing, that if the patient is not responding in 1 to 2 doses of ergometrin or methadone, then please don't stick to 5 doses. You move on to the next in protocol, that can be carboprost. And in written placenta and in hypertension, do not use methadone. There you can use carboprost or misoprostol. So the advanced intervention are completed the PPS bundle, call for more help, assign tasks, insert IV cannula and medications, repair the tears if there is traumatic PPH, remove the placenta and clots. See, if there are local tear which can be manageable from below, you manage it. But if the patient is sinking, then even for vaginal tear, you take the patient to OT. Hemodynamically unstable patients should not have their tear repair in liver. And if you are suspecting broad ligament hematoma, higher bleed, then please take the patient immediately to operation theater. And NASG, the main two advantages of NSG are this: when we transfer the patient, and suppose my hospital is very busy and my OT is occupied, and the second patient is also in shock, then I can make the patient wear NASG, and that time can be utilized with the NASG, and patient's BP can be maintained. Sometimes there may be more than one cause of postpartum hemorrhage. Many a times, with traumatic PPH, patient bleeds so much that her uterus also becomes atonic. So we have to be careful about that. One of the important prophylaxis for postpartum hemorrhage is optimizing hemoglobin. So it should be our goal to make the patient's hemoglobin 11, preferably 12 gram percent, and if not 12, then at least more than 10 gram percent before she delivers. And for this repair of vaginal and cervical lacerations, systematically, every obstetrician should know how to take it systematically with the help of sponge holding forceps, as it is shown in picture. And for uterine, suppose if you want to ligate the cervical artery or uterine artery, then you have to take the full thickness of the lumen to occlude it. And bimanual compression and aortic compression are temporarizing methods, and everybody should know. You see in the picture, bimanual compression is being shown. And if the patient, you are using these uterotonics are all conservative methods of management of postpartum hemorrhage. And if I talk about uterotonics, then we have the choice of oxytocin, then methotrexate, then carboprose, then misoprostol. And we use these uterotonics only when the patient is hemodynamically stable. Next is NASG along with UBT. Non-pneumatic anti-shock garment we use for only for when the patient is in shock and we have to transfer the patient or patient is waiting for OT. And in PPH bundle, after uterotonics, there is a role of mechanical methods, and that is uterine balloon therapy. UBT means uterine balloon therapy. But remember one thing, two important prerequisites for uterine balloon therapy. One is that the patient should be hemodynamically stable. And the second, we have ruled out all type of traumatic hemorrhage and latent placenta. It is the treatment only for atonic postpartum hemorrhage. So these are the pictures of temporary control of bleeding, and by abdominal aorta compression, we actually mimic it with the internal iliac artery ligation, temporary internal iliac artery ligation. Because internal iliac artery is a branch of abdominal aorta. So you see here, L4, L5 is the place where it divides into two common iliac arteries, and the sacroiliac level, each common iliac artery divides into external iliac and internal iliac, and this is the internal iliac which gives maximum supply to the uterus, cervix, and vagina. And this is the place where we stand just straight in front of the patient and press it with the fist, one hand with the fist, and then we compress the abdominal aorta. We apply a downward pressure with closed fist over abdominal aorta through the abdominal wall, just above umbilicus, slightly to the patient's left, because among the two blood vessels, inferior vena cava and abdominal aorta is slightly towards left. And with other hand, you see here, with other hand, we palpate the femoral pulse to check adequacy of compression. Because this femoral artery is a continuation of external iliac artery, so if abdominal aorta is adequately compressed, then there will not be any pulsation in the femoral artery. If there is pulsation in the femoral artery, you have to compress it more and maintain the compression until bleeding is controlled or she reaches the operation theater. This is a method which is showing uterine balloon tamponade, how it is inserted. The main function of uterine balloon tamponade is that its pressure inside increases when we push the fluid, and that occludes the blood vessels, hydrostatic pressures. But the main prerequisite for this is exclude traumatic postpartum hemorrhage, and patient should be hemodynamically stable. I remember one patient had a cesarean section, and in ward after 2 to 3 hours, she went into shock because of bleeding PV, and someone inserted a balloon, uterine balloon, in that patient, and that patient died after 12 to 13 hours. Because when the patient was in shock, there was no role of uterine balloon. The only thing is hysterectomy left for that case. So this is the picture of cervical tear. This is the picture of NASG, and everybody should know how to apply this and how to remove this, how to sterilize this. It does not treat PPH, but it gives time to see treatment. And every ambulance in our hospitals, every ambulance which is transferring such women should have an NSG garment. And even the drivers also know how to apply NSG garment, helpers and drivers. So a woman with NASG on, you see here, this flap. So it can be opened, and with this garment on, we can do a definitive surgery in OT. So that is the beauty of NASG. The concept has come from war, where usually soldiers used to be brought with this garment. So we have discussed about conservative methods, that is uterotonics. We have discussed about uterine balloon therapy, and now comes the role of surgery. So see, uterine balloon, you can either put in labor room, or you can put in maternity OT also. And if the patient is still hemodynamically stable and the uterine balloon is not working, patient is still bleeding, then you have to open the abdomen. I always say that when you are opening an abdomen for postpartum hemorrhage, preferably you open by a longitudinal incision. And the first step is either uterine artery ligation, or it is called stepwise devascularization, or a brace sutures. If you are well conversant in brace sutures, you can apply brace sutures. B-Lynch, Chose, and Heman suture are very good sutures. There are 1,000 types of sutures. Brace sutures are written in literature. A human brain cannot remember so many sutures. Even I also don't remember. But I can at least guide you that with knowing only 3 types of brace sutures, B-Lynch, Heman, and Chose, you can anytime handle any type of postpartum hemorrhage where there is a requirement of application of uterine compression sutures. Regarding step-wise devascularization, the first thing is that you have to ligate the uterine artery, and it is always desirable to ligate both the uterine arteries, because 50% supply is coming from each artery. And then next step is uterine ovarian anastomosis ligation. When we were doing MD, we were taught that ovarian artery ligation. Ovarian artery ligation is a misnomer. Ovarian artery is a direct branch of abdominal aorta, and we do not ligate the ovarian artery. Rather, we ligate the anastomosis of ovarian branch of uterine artery and uterine branch of ovarian artery, and that anastomosis lies in the broad ligament just below the insertion of the ovarian ligament. So you just find out a place, a vascular space just below follow the ovarian ligament, find out a place in the broad ligament just below it, and you see the vascular anastomosis, and then pass the needle through 2 avascular areas and just tie it. So it's written in red. Conservative methods are used only when the women is hemodynamically stable. So I'm doing stepwise devascularization and brace sutures only when my patient is hemodynamically stable. If the patient becomes unstable, that at any moment I have to do a radical surgery, either subtotal or total hysterectomy as per the requirement. Wherever a patient can be treated with a subtotal hysterectomy, we should always do a subtotal hysterectomy because it is very easy and fast. Total hysterectomy we need to do in a case of placenta accreta spectrum, or where there is a wall tear, or where there is placenta previa, all this. So the first 60 minutes is the golden hour of postpartum hemorrhage, and you should not become late. Uh, it is better that you give medical management only for 20 minutes. If the patient is not responding with medical manage, then you move to the techniques like uterine balloon therapy, stabilized devascularization of brace sutures. And if the patient is not responding in 40 to 50 minutes, then quickly do the surgical procedure. Remember that this medical management and these techniques, they all are meant only when the patient is hemodynamically stable. If while giving medical management I notice that my patient has become hemodynamically unstable, then I will not do this step. I will immediately perform hysterectomy. And that's why I always use the word escalate or move up the protocol. This means that you are using oxytocin, if a patient not responding to oxytocin, you are using methoxine. If no contraindication, if patient is not responding to methoxine, you are using carboprost or misoprostol. Even for carboprost, there are total doses are 250 microgram, and every 15 minutes it needs to be given. But if the patient is, so that means you should not use all the 8 doses and taking 2 hours in managing PPH if the patient is not responding in 1 to 2 injections of carboprost. But that 15 minutes is okay. And then immediately move to the next. You don't have to stick to carboprost. So medical management, then uterine balloon therapy, and then open the abdomen, do the brace sutures, and try an artery ligation or ovarian uterine artery ligation or internal iliac artery ligation. But remember one thing, the patient is still hemodynamically unstable. If patient has become hemodynamically stable, if the patient has become unstable, then you will not perform an internal iliac artery as a first treatment, rather you will go for a hysterectomy. So
Summary है इसको you can skip.
timely referral has been done, and this is the summary.
ये भी summary है हाँ.
This is the summary here. So now regarding referral and transfer, the patient should have 2 IV fluids. Patient should have oxytocin on flow, and if you can put a uterine balloon, there is no traumatic PPH. Put the balloon, and for surgical trauma, try to repair it as much as possible, or do a good packing below. Intrauterine. Remember one thing regarding packing. I want to clear one confusion that there is no role of intrauterine packing now. Smita Patil died of postpartum hemorrhage because her uterus was not removed and her intrauterine packing was done. And later she succumbed to death. Our intrauterine packing has been replaced by uterine balloon. So we do not do intrauterine packing, but in a local tear, you can put a pack.
These are referral
We
protocols.
should transfer the patient with the NAS zone if it is indicated, and with the skilled staff, and the IV fluid should always run. And patient requires a continuous monitoring. So the 5Gs for PPH are GPS tracking, real-time ambulation position, shortest route, geotagged facilities, finds nearest center with OBZ plus blood bank capability, guideline-based decision tool, appropriate apps prompts to ensure stabilization before referral, and gigabyte connectivity, live video consent.
You can skip
and
this
golden hour
also.
dashboard.
5 user documentation important.
Documentation and debriefing is very important. I have one very beautiful documentation chart which I have shared at many platforms, and those who are interested can ask me or Delhi Gani Forum. And that's such a beautiful chart. Here in that chart, you mention everything. When the senior obstetrician come, when the junior obstetrician came, when the anesthetist came, when the blood bank was alerted, when IV cannula first started, when IV cannula 2 started, which fluid was given, when first ultrasonic given, when second ultrasonic given, when the bladder was catheterized, when our RPUC is removed, when everything, when first blood given, when second blood given. So it will work as a checklist. It will not make you it will not let you make a mistake. You know what is the next step, and you will not forget it because it is written in front of your eyes. And second thing, it will save you in the court of law. So this documentation is very important. And what is debriefing? When the patient has PPH, has developed PPH, please send some responsible person outside to tell the relative that this patient has had PPH and we are managing, and these are the possibilities, and keep updating.
So
And then after
ओनली 2 minutes लेफ्ट हैं, तो थोड़ा सा अपना जल्दी करेंगे,
Yeah,
यदि
yeah.
बहुत लंबा है हाँ
Yeah,
क्विक
it is
करके
it,
कर देते हैं।
yeah, it's done. Everything has been done and said, madam. So
हाँ ये सब रिपीटिशन ही
thank
है।
you so much. Yeah, yeah. Thank you so much. I will stop
तो
sharing. Yeah,
यस
yeah.
यस, सही थी। प्लीज फर्स्ट ऑफ ऑल शो द सर्टिफिकेट ऑफ डॉक्टर शशि लता काबरा मैडम।
Thank you
Dr.
so
Shashi,
much.
this is a small token of appreciation from respected Dr. Sharda Jain and team, and please accept it. And with folded hands, we say thanks to you for coming and
Yes.
giving a smart talk. I must say smart talk because when you know everything. So now I request Dr. Archana Sharma to say and give her expert opinion, and she can conclude.
Thank you, Madam Dr. Shashilada. It was a wonderful talk you have given. Every time when it was a 95th webinar. Every time when we hear actually the PPH presentation, something new comes out of this. One point or something you learn always. So this is a wonderful drilling, and this was a wonderful program, and it was given by us to Dr. Shardajan Madam and Dr. Archana Verma Madam, and this is a wonderful platform to reduce the maternal mortality. We can teach so many doctors in the periphery also, and they can also work for that. So it was a wonderful talk, and it was very nicely elaborated by Madam. Thank you very much, Dr. Shashilata, for this wonderful talk.
Yeah, thank you so much.
So many new points she was talking, and very nice. I think we need to have many more sessions with Dr. Shashi.
I was saying this thing every time you hear this particular PPH talk from somebody, you get very much sometimes new points out of that. So this was a wonderful talk. So we can have Dr. Shashi for further sessions also.
Thank you so much.
And we will call her to Ghaziabad also. Matlab she is the one person who we should invite.
Yes, definitely. Why not?
Yeah, I always tell people that you can call me. I always share my phone number and they can call me 24 into 7, irrespective of the place where I am. And I will always feel happy to save a woman by giving advice.
Okay, very nice, very nice.
Very
You
कहीं
are
भी
one of
मेरा
the,
फोन जहाँ लगता है वहां मुझे आप फोन कर सकते हो, मैं रिस्पॉन्ड करूंगी.
you are one of the very एक होता है ना aggressive worker, बहुत और यू आर वर्किंग। एक आप ही बोलते हो ना बहुत कुछ हिंदी का बड़ा अच्छा सा बोल के बताओ ना जरा जिसमें आप
क्या?
कहते हो बहुत संघर्ष करना है, वो कौन सा है जिसमें बहुत अच्छा से बोलते हो कि फोकस वाला, क्या बोलते हो?
अभी तो मुझे याद नहीं है, पर मेरी मदर मुझे हमेशा यही बताती है कि किसी भी चीज से डरना नहीं है, पीपीएच को नाइटमेयर बोलते हैं. तो मम्मी हमेशा यही कहती थी, बचपन में मुझे समझाती थी, किसी चीज से डरना नहीं, उसके ऊपर चढ़ के उसको जीत लो. तो मैं यही कहती हूँ, पीपीएच से डरना नहीं, हम ऑब्स्टेट्रिशियन है, हमें स्किल्ड होना चाहिए, हमें हर तरह का टेक्निक सीखना चाहिए, और वी शुड विन पीपीएच. पीपीएच को हमसे डरना चाहिए, हमको पीपीएच से नहीं डरना चाहिए.
पीपीएस तो नहीं डरेगा,
एग्री मैम?
पीपीएस तो आएगा, पीपीएस तो आएगा,
नहीं, वो
पीपीएस
वो
नहीं
हमसे कंट्रोल हो जाएगा, वो
डरेगा।
हमसे
But
कंट्रोल हो जाएगा ना, वो हमसे
हाँ,
कंट्रोल हो जाएगा,
but
मतलब.
but we
कंट्रोल,
should create a win-win situation over the PPH.
हाँ हम ना उससे उससे निपट लें, यही बहुत रहेगा कि वो हमें ना निपटा के चला जाए। तो मतलब एक वही वाली चीज है कि वो एक
ये यदि
आगे।
हम टाइमली हर काम करें, हर चीज हम टाइमली करें, गाइडलाइन को फॉलो करें, तो हम हर विमेन को बचा सकते हैं पीपीएच के. ये
बिल्कुल सही है। मतलब पीपीएच की वुमेन सचमुच पीपीएच को प्रिवेंट करना है, पॉसिबल है, बट स्टिल पीपीएच होगा, बट होने दो उसके, आप उसको मैनेज करो, मतलब
एग्जैक्टली,
उसको।
उसको हो भी गया तो उसको कैसे टाइमली किस समय लेना है, वो जरूरी है. क्या होता है, पेशेंट क्यों मर जाता है? क्योंकि हीमोडायनामिकली अनस्टेबल हो गया, और अभी तक हम कंजर्वेटिव मेथड से यूज किए जा रहे हैं, तो इसलिए होता है ना, तो वो बहुत जरूरी है.
सामान्य तरीके से बहुत सशक्त संघर्ष करते हुए इस पर पीपीएच पे विजय हासिल करनी होगी। मतलब ये
Definitely.
अपना, जब हम अपना मुद्दा यही बनाएंगे, फाउंडेशन हमारी यही रहेगी, मिशन नींव का भी मतलब यही है। अपने आप से कुछ चीजें फिर मतलब
और,
अलाइनमेंट होना शुरू हो जाता है।
और मैं.
अलाइनमेंट इज वन थिंग, जो आप जब तक अलग अलग चलेंगे, जैसे अभी एक ग्रुप था उस पे कोई एंटी एचपीवी वैक्सीन बोले जा रहा, भाई तुम्हें नहीं देनी मत दो, तुम्हें नहीं खुश हो मत करो, बट व्हाई टू से लाउडली। आप एक ग्रुप में पर्टिकुलर डॉक्टर हो के डॉक्टर के खिलाफ बोलने से क्या मिल रहा है? नहीं मिलेगा। आपको नहीं देनी, मत दो, अलग से ग्रुप लो, अलग से टीचिंग लो, सब कुछ करो। ग्रुप में तो ऐसा लगता है ना कि पता नहीं क्या चल रहा है, और वो सोशल मीडिया पे सब कुछ है। अब क्योंकि इंडिया में ऐसा वैसे ही कौन सा बहुत वैक्सीनेशन अब बहुत हाई चल रहा है, स्क्रीनिंग भी नहीं चल रही, वैक्सीनेशन भी नहीं चल रही, कैंसर आएगा तो कंट्रोल भी तो करना सीखना चाहिए हमें। और दूसरे की तारीफ करना और अप्रिशिएट करना एक बहुत बड़ा गुण होता है, बहुत बड़ा गुण होता है। और बीइंग ट्रूथफुल, अगर आप ये तीन चीजें आसानी से नहीं मिलती हैं कहीं पर भी, जो कि डॉक्टर्स में मिलती हैं। चलो शशि काबरा जी, आज आपसे सुन के बहुत अच्छा लगा। ऐसे ही हम लोग साथ साथ चलेंगे, आगे बढ़ेंगे टुगेदर। एंड कीप टेलिंग मी, और वेन एवर यू वांट, यू हैव टाइम, प्लीज डू ज्वाइन, क्योंकि मैं बार बार राष्ट्रप्रथम में डालती रहती हूँ। यू कम एज एक्सपर्ट, है ना, गिव योर ओपिनियन किसी भी पॉइंट पे ना, शुरू शुरू के पॉइंट पे। सपोज आपने एक बार बना लिया कि मुझे ये जो आपने मिथर्जिन का बोला, बहुत अच्छा बोला कि भाई आपको कैसे देना है, 5 तक वेट नहीं करना। कभी गलती से इसमें 5 डोजेस लिखी हुई तो आप 5 तक दिए जा रहे हो। आपको ना वो 15-15 मिनट पे मॉनिटरिंग कर रहे हैं तो आप 15-15 मिनट पे किया जा रहा है। अरे आप 2 मिनट बाद बीपी देखो, 3 मिनट बाद भी देखो, जैसी
एग्जैक्टली।
सिचुएशन है वैसी देखो। गाइडलाइन पे तो ये इसलिए लिखा हुआ है कि आप कम से कम वो प्रेशियस टाइम भी ना खो दो, वरना अदरवाइज कितनी बार तो जरूरत होती है, तो हम तो 2-2 मिनट बाद पेशेंट को ही देखते रहते हैं,
यस
बार
मैम,
बार
यस
बार
मैम,
बार।
ये मैसेज
ऐसा
देना
नहीं
बहुत
होता।
जरूरी है।
हाँ, ये
हाँ,
मैसेज देना बहुत जरूरी है। कई सारे
इसीलिए मैंने
मान लो
आज स्पेशली इसमें फोकस किया मैम।
हाँ, ये अच्छा बोला। मतलब और जो है था पीपीएच कॉन्शियस, जो आपका वर्ड था वो भी बहुत अच्छा था। सो बिकॉज आई वाज लिसनिंग वेरी केयरफुली। तो मतलब सचमुच में दूसरे से बहुत आप पता है, जब कोई बोलता है, ऑडियो विजुअल का जो इफेक्ट होता है वो बेस्ट होता है। अपने आप से गुनगुन 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 गूगल पे पढ़े जाओ और या कॉपी पेस्ट करे जाओ, कुछ करे जाओ, उससे कोई फर्क नहीं पड़ता। मोटिवेटर का बड़ा रोल है इस जिंदगी में। तो जैसे मैंने तो ये देखा, मेरी तो डायरेक्शन भी चेंज हो गई काम करने की। शारदा जैन मैडम ने जब बताया, समझाया कि ऐसे करना है इसको, 10 लोगों का चिंता मत करो, अपने सिर पे हेडेक पे टेंशन मत, मतलब टेंशन मत पालो सिर पे कि मुझे 100 लोग चाहिए, दूसरे को बताना है हाउसफुल था टॉक में, या ऐसा था या वैसा था। जस्ट डोंट बॉदर अबाउट एनीथिंग। आप सबसे जाओ, पहला टॉक दो और चले आओ वापस। और जिसको आना है सुनना है सुनेगा, आप मत ऑडियंस का वेट करो। जैसे वही है ना, जैसे बैड लक, मौत ना किसी का इंतजार कर रही, तो आप ही क्यों करो किसी का इंतजार। ठीक है, जिसको आपका रिस्पेक्ट होगा, जिसको पता लगेगा, जिसने ब्रोशर नहीं देखा हुआ, तो वो पछताएगा अपने आप से, अगली बार दौड़ के सुनेगा। कहीं ना कहीं तो होगा ही ना उसको। हम कितना समझा लेंगे, लोगों को नहीं समझ में आती है लोगों को, है ना, ऐसे ही होता है ना। हम लोगों को मिलके, मतलब सचमुच में बीइंग रिस्पेक्टफुल इज अ बिग थिंग।
यस मैम।
आप पेशेंट देखो, जो गवर्नमेंट जॉब में काम करते हैं, जो बहुत सीनियर डॉक्टर्स हो गए, आप देखो वो शुरू, जब हम पीजी थे तब हमारी प्रोफेसर इतना प्यार से पेशेंट से बोलती थी, तब तो ऐसे कोई कानून नहीं चले थे। बट फिर भी, रानी आप ऐसा कर लीजिए, रानी आप ऐसा आ जाओ, तुमको ये परेशानी होगी, तुमको वो परेशानी होगी। मेरा मतलब, हम लोग तो इतने डेडिकेटेड तरीके से लिखे पढ़े से लोग थे कि आज भी हमें कोई नहीं कहता। मैंने तो जब ये पढ़ा सुना कि रेस्पेक्टफुल मैटरनल केयर या मैटरनिटी केयर और या लेबर गाइड, तो हमने कहा ये तो हम शुरू से ही करे जा रहे थे बेचारे, बिल्कुल दौड़ा दौड़ा हर चीज बता के, समझा के, काउंसिल करके। जो भी पेशेंट को जरा सा भी हाई रिस्क होता था, उसके लिए स्पेशल वार्ड कहते थे उसे, उस टाइम एचडीयू नहीं कहते थे, स्पेशल वार्ड में रखा जाता था। एएमयू में बहुत हाई लेवल डिफरेंट तरीके से काम किया जाता था, बहुत ज्यादा। और इतना वहां, और जैसे एक कोई वीआईपी आ जाता था तो उसका पोस्ट एमडी, जैसे आई वाज मेडिकल ऑफिसर, तो आई वाज डूइंग एसआरशिप, तो उसका पल्स बीपी लेने का काम मुझे दिया गया था। और ये कहा था ये हमारी सबसे अच्छी वर्कर का है। और बहुत ही सुपर हाई वीआईपी थे वो। तो उनको सेप्टिस, जो तुमने बताया स्मिता पटेल हो गया था, वैसे ही उनको हो गया था, बट शी केम आउट, शी वाज सेव्ड। तो मतलब आप ये देखो, उन्होंने, कंसल्टेंट ने बीपी पल्स के लिए, उस टाइम मॉनिटर नहीं होते थे, तो डॉक्टर को बिठा दिया। कौन करेगा ऐसा फिर। और हम लोग बहुत उससे डर के मारे भी और रेस्पेक्टफुली भी, भाई हमारी मैडम ने कहा यार इतने बड़े वीआईपी हैं, इनका सुनना है, इस टाइप से ना कर करते। कोई दादागिरी नहीं छांट रहा था कि हमारी ड्यूटी खत्म हो गई 2 बजे तक तो हम जा रहे हैं। पूरा लिख पढ़ के, चाहे 4 बज रहे थे, पूरा काम करके ही जाते थे। वो डेडिकेशन आज के जमाने में ना, सबके इधर से उधर तक जो घूमने फिरने का कंसेप्ट आ गया, प्राइवेट मेडिकल कॉलेजेस का कंसेप्ट आ गया, लोग एक दूसरे से कंपटीशन लड़ाते हैं, उसका कंसेप्ट आ गया। इसलिए प्रॉब्लम मुझे लग रहा है थोड़ी और भी बढ़ती जा रही है कहीं ना कहीं। पेशेंट ही कंफ्यूज रहता है, मुझे कहाँ जाना है। एक को दिखाता है, 4 जगह दिखाता है, फिर वो सुनता नहीं है किसी भी डॉक्टर की। तो अगर आप लोग, जैसे अभी कोई कह रहा था आसाम का, पेशेंट को एनीमिया है और वो लोग सुनते नहीं हमारी। वही नहीं सुनते हो तो कार्ड पे लिखो, बोलो नमस्ते, जाओ। तुम्हारे लिए हमने सरकारी हॉस्पिटल खोला हुआ है, वो भी हमारा ही हॉस्पिटल है, जाओ वहां पे जाके कराओ, नहीं इंजेक्शन लगवाओ और आओ हमारे पास, हम तभी इलाज कर पाएंगे जब 12 होगा हीमोग्लोबिन। आप हिम्मत तो रखो कहने की। चलो, ओके।
यस, ओके।
थैंक
नमस्ते
यू।
अर्चना मैम, नमस्ते। बहुत अर्चना मैम।